Hello everyone, my name is Sheila Naboyambo, a PhD scholar at the Infectious Diseases Institute, registered at the Makerere University. For this poster presentation, I'll be presenting some of the results from my PhD research. In this study, we investigated the circulating levels of angiogenic factors and their association with preeclampsia among pregnant women in Mulago Hospital. A brief background. Preeclampsia is a hypertensive disorder of pregnancy that affects women at 20 or more weeks of gestation. Preeclampsia is a major cause of maternal and newborn morbidity and mortality, affecting 3 to 8% of pregnant women worldwide. It can lead to adverse consequences such as end organ damage for the mother, preterm birth, and reduced cognitive ability among affected children. In Uganda, preeclampsia accounts for 6% of the 336 deaths per 100,000 live births among mothers. The pathophysiology of preeclampsia starts with abnormal placentation, which includes improper formation of placental blood vessels that supply the growing fetus. This results into formation of an ischemic placenta that releases factors into maternal circulation. These placental factors result into systemic vascular dysfunction that leads to the characteristic features of preeclampsia, including high blood pressure and excretion of protein in urine. Angiogenic factors are proteins involved in the formation of blood vessels during placental development. Previous research indicates that the preeclamptic placenta releases abnormal levels of 3 major angiogenic factors into maternal circulation compared to the normal placenta. These abnormal levels are shown to occur before clinical onset of preeclampsia, and therefore these could be used as potential candidates for the diagnosis of preeclampsia, which currently relies on clinical symptoms. However, in Uganda, there is currently limited documentation on the angiogenic factors and their association with preeclampsia. In this study, therefore, we investigated the circulating levels of 3 major angiogenic factors, including VEGF, PLGF, and soluble FLT1, and their association with preeclampsia among pregnant women in Uganda. We also set out to determine their diagnostic performance for preeclampsia. Please refer to the bottom of the poster for the full name of the abbreviated angiogenic factors. Using the case control study design, 106 pregnant women with preeclampsia and 106 women with normal pregnancy were enrolled from the maternity ward and the antenatal clinics of Mulago Hospital. Demographic and clinical characteristics and anticoagulated blood samples were collected from the participants. Blood samples were processed in the IDI Translational Research Laboratory to measure the circulating levels of VEGF, PLGF, and soluble FLT1 using Luminex and enzyme-linked immunosorbent assays. We used our statistical programming environment to analyze the study data. We used descriptive statistics to summarize patient characteristics, Mann-Whitney U-test to compare continuous variables, and Fisher's exact test for comparing categorical variables. We used conditional logistic regression to explore the association of angiogenic factors with preeclampsia. We also used trained logistic regression to determine the diagnostic performance of these angiogenic factors among the pregnant women in Uganda. The mean age of the study population was 25 years in both cases and controls. All mothers conceived naturally and were of African descent. Compared to the controls, women with preeclampsia had low circulating levels of VEGF and PLGF and high circulating levels of soluble FLT1. This confirms an imbalance of circulating angiogenic factors associated with preeclampsia in previous studies. We found that increasing levels of soluble FLT1 were associated with an increased likelihood of developing preeclampsia, while increased levels of PLGF were protective of preeclampsia. We further determined the diagnostic performance of these angiogenic factors and found that the ratio of soluble FLT1 and PLGF had a high performance with a sensitivity and specificity of 92 and 91% respectively, and an area under curve of 95%. In conclusion, the expression profiles of angiogenic factors differs in pregnant women with preeclampsia compared to normal pregnancy, confirming an abnormally formed placenta. These angiogenic factors could therefore be exploited to confirm clinical diagnosis of preeclampsia. There are currently no effective preventive measures for preeclampsia, and angiogenic factors could still be explored for their use to guide decision-making towards close surveillance of pregnant women at high risk of developing preeclampsia. Uganda is a resource-limited country that faces a high burden of maternal mortality due to preeclampsia, and it could benefit from appropriate allocation of resources as a result of close surveillance of pregnant mothers at high risk of developing preeclampsia. With these results, we recommend longitudinal studies that could investigate the circulating levels of these angiogenic factors throughout the whole period of the whole gestation period. This would better inform on the usability, on the applicability of these angiogenic factors. I would like to acknowledge the support given to us by my PhD funders, which is MUI Plus, my PhD supervisors, the IDI Translational Research Laboratory, and the IDI Research Department. Thank you all for your attention.